Today we're going to talk about a very, very interesting and an important discussion topic of hyponatremia. Now, hyponatremia is one group of disorder which has got a lot of endocrine issues. So what we'll be focusing today is largely in terms of the endocrine issues. And hyponatremia is one condition which, if it is diagnosed at the right time, we can manage it appropriately, we'll have a good outcome. But if we delay the diagnosis, there could be a problem. With this first case, a 14-year-old boy with drowsiness who was found to be hyponatremic, and on evaluation, the child was clinically euvolemic. The urinary sodium was done, which was found to be high. So we have hyponatremia, which is a dilute blood with a concentrated urine. So urinary sodium of 100 would mean that the osmolality would be around 400. So roughly you make it 4 times, it gives you the osmolality from that regards. It was around 300 and was diagnosed as SIADH. So this is a euvolemic hyponatremia with a concentrated urine. SIADH is a reasonable diagnosis. But what happened with this child was that had a severe worsening here. And when the endocrine team was evaluated and asked for, it was found that this was actually not a case of SIADH. It was actually a case of multiple pituitary hormone deficiency. So again, before we start considering different diagnoses, so a lot of these hyponatremia will not be endocrine. But if you identify an endocrine cause, unless you treat it, there would be a problem. And this is a common situation wherein SIADH is often misdiagnosed in somebody who has a multiple pituitary hormone deficiency. And we always say that SIADH is a diagnosis of exclusion. You have to exclude cortisol deficiency, renal insufficiency, hypothyroidism, diuretic use before you make a diagnosis of that. And that was the error which happened in that situation. The other situation, again, a 16-year-old girl with abdominal pain, recurrent abdominal pain was there and now presented with seizures. So she was basically called, we were called when the sodium was found to be low. So this was a child who had euvolemic situation with hyponatremic seizures. And when we did evaluation, it found out that she was euvolemic, every other workup was normal. So this was SIADH. Now, the message again is that don't end your story with SIADH diagnosis, because SIADH is just a syndrome. You need to go at an underlying cause. Now, in this setting, we had a girl, a young girl with recurrent severe abdominal pain and seizures. So what was very important and what we got at that point of time was the urinary porphobilinogen, which was positive for porphyria. So what these two cases tell us is that don't be in a rush to diagnose SIADH, exclude the possibility of other endocrine causes which may mimic SIADH, or other causes, pathologies like porphyria becomes important. And that is why hyponatremia is a challenge. If you identify it at the right time, identify the diagnosis, the treatment will cause a very good outcome. But often there is a confusion which may happen in that regard. So all of you can go and have a look at our website, learning.growsociety.in, where there are a lot of information available about different aspects of pediatric endocrinology. We have got over a number of modules, around 100 modules, which are available along with assessment and validated tools. We got specific courses in the form of fellowship and diploma courses, along with courses for postgraduates and a specific electrolyte course as well. We run 3 grand rounds every month. So we have got this, which is a grand round, then there's a postgraduate grand round, and there's a postgraduate lecture series. And later today, we have got a postgraduate lecture series on growth hormone therapy. That's 9 p.m. later today, which you can join from that regards. There are publications, both basic and advanced, which you can access. And our mobile application, we'll also use that application to decide about how to treat hyponatremia, which will be identified in this perspective. Now, before we go into details with regards to the various causes, evaluation, and cases, we need to understand the basic homeostasis. Now, what we need to understand is that when we talk about the sodium level, the sodium concentration in the body largely depends not on your sodium, but on the free water. So sodium is a major determinant of volume, and free water is the major determinant of tonicity, that is sodium levels. So if you now think about conditions which are more common causes of hyponatremia, be it fluid overload like cardiac failure, liver disease, nephrotic syndrome, all those situations, conditions in which you have got inappropriate ADH excess or appropriate AVP excess, fluid overload is a major cause of hyponatremia. What are the conditions which are associated with sodium loss as a cause of hyponatremia? So any cause of renal or extrarenal sodium loss. So we are saying that fluid excess is a major cause, but if you're losing a lot of sodium from your gut, like diarrhea, a lot of sodium through your urine because of diuretics, tubulopathy, RTA, or RAS defect, you will have hyponatremia. But do you think there also is an issue of free water there?
Yes.
Why?
Because their water is also lost.
So, because you lose water, you will have a situation in which you will have excess production of AVP. And whenever you have excess production of AVP, your free water level will go up and you will have hyponatremia. So anybody who has got chronic hyponatremia will have an excess of vasopressin, whether it is appropriate or inappropriate. And ultimately, it is the free water excess which is the major cause of hyponatremia. Salt loss can cause that, but then body will adjust. As soon as you lose salt, body will try to develop mechanisms to do that. But if you've got too much free water, it will be very difficult from that perspective to identify and evaluate in that regards. Now, there are two ways your fluid status is assessed. One is via thirst, so how much water you are taking. And the second, of course, is how much urine you are passing. So the thirst is the main defense against hypernatremia. If your sodium goes up, you will stop your urine output, but you have to drink water to ensure that the sodium levels come down. On the other hand, if you have hyponatremia, just by stopping to drink, your hyponatremia will not be corrected. You will have to shut down with regards to the urinary concentration which is happening. You have to allow the urine to be lost, and that will be helpful. So if you talk about hyponatremia, the major defense against hyponatremia is the body's capacity to lose free water. Now, if you go other way around, the most common cause of hyponatremia would be the situations where the body cannot lose free water. And if you cannot lose free water, your free water will be more and sodium will be going down. So in a nutshell, every child who has got hyponatremia has got high AVP, has got a low level as far as the urinary loss is concerned, and the urinary concentration happens. So most cases, your urinary sodium levels would be in that setting on the higher side. While the normal response should be that the urinary sodium concentration should be low in that setting. And this is an important thing to remember from that regards. Now, in situations wherein your tone increases, now this is the other way around. If your tone increases, the hypothalamus, the circumventricular organs which are located in the organum vasculosum of lamina terminalis and subfornical organ will say, okay, now we need to get more free water in the system. What they will do in that perspective is that they will then secrete AVP, which will decrease urinary water excretion, causing increased free water. This is a normal response in the setting of somebody who is developing increased osmolality, increased tonicity, or hypernatremia. Let's put it in that perspective. Now, in a situation where volume goes down, and whenever your volume goes down, the major response comes from the renin-angiotensin-aldosterone system. And this RAS system will then do a very important thing. It will allow sodium to be resorbed along with loss of cyan. If you absorb sodium, what are going to you lose?
The potassium.
And?
The potassium and all the other positive ions.
Potassium and proton. So these two things will definitely be lost. So anybody who is having hypovolemia. So let's talk about diarrhea. Let's talk about diuretic loss. Let's talk about tubulopathy. Let's talk about RAS defect. You will have RAS excess. Unless, of course, there is RAS defect, you can't have RAS excess. Everybody else will have RAS excess. When you have RAS excess, your potassium will come down and you will have alkalosis. So hypokalemic alkalosis is a normal response to somebody who has got a low level of sodium if the RAS axis is intact. If the RAS axis is not intact, of course, you will not lose potassium and you will not lose proton in that perspective, and that could be a problem in that regards, and you will develop a hyperkalemia and acidosis. So anybody who has hyponatremia with hyperkalemia with metabolic acidosis, you're talking about a defect right at the renin, aldosterone production, aldosterone action, and all those situations will have a problem which will happen, and that's what the RAS defect will present with. Hyponatremia, hyperkalemia, and metabolic acidosis would be the usual response in that setting. Now, as discussed, normally we say when your sodium goes down, your potassium goes up. When your sodium goes up, so in pathological causes, if your sodium goes up, your potassium goes down. So typically I said if you have hyponatremia with hyperkalemia, you're talking about largely a renin-angiotensin aldosterone defect. What other condition will cause hyponatremia with hyperkalemia? Vibha. Hyperkalemia. So hyponatremia, hyperkalemia, renin, angiotensin, aldosterone, pseudohypoaldosteronism, CAH, all those things are there. What other condition causes hyponatremia with hyperkalemia? This is a very common condition. So we talked about adrenal problem causing hyponatremia, hyperkalemia. What else will cause hyponatremia and hyperkalemia? Diarrhea, no? Potassium sparing diuretic is the RAS axis only, na? So the kidney disease, any cause of acute or chronic, not even acute also causes hyponatremia, hyperkalemia. Now, what is the difference between hyponatremia seen in a renal problem versus hyponatremia in the adrenal problem? Renal problem is because of?
Because
fluid overload. That's a dilutional hyponatremia. While in the setting of adrenal problem, you will have hemo concentration, that is dehydration. So again, if you have hyponatremia with hyperkalemia, the first question you will ask is whether this is renal or adrenal. And this will become relevant because once we discuss this in that regards, the answer to that question is to look at hydration status. If the patient is dehydrated, this is mostly a salt wasting crisis because of an adrenal problem. If the patient is actually fluid overloaded, there is edema, it is more of a renal problem. Which biochemical parameter will tell you that the patient is having hemo concentration or hemodilution, because often volume status in young children may be difficult to assess.
And uric acid.
Yes, so uric acid and hematocrit. Why uric acid?
When the volume is more, uric acid is excreted more.
The excretion of uric acid is directly proportional to the blood volume. More the volume, more loss of uric acid, low uric acid. So if you have renal problem, unless of course the uric acid excretion is defective and that you may have hyperuricemia, or let's say if you have SIADH, in that setting your uric acid will be low because your volume is more. While if you have an adrenal pause, your uric acid will be high. So looking at hematocrit and uric acid, you will know which way to go forward. So I said hyponatremia with hyperkalemia, renal versus adrenal. What about hyponatremia and hypokalemia?
This is mainly due to tubulopathy or diabetic use.
So any tubular dysfunction and diarrhea. So you are losing both sodium and potassium, either through your gut or you are losing through the kidney. So you will have either diarrhea or you will have a tubulopathy, Bartter syndrome, Gentleman syndrome. You can have cystic fibrosis also. You will be losing to the sweat. So you're losing it from somewhere and that will cause a problem. So again, understanding the pathophysiology will help in that perspective. Now, if you give too much volume or your volume becomes more, the body will say, okay, I have to shed this volume. And how do it detect? It will then have a signal in the heart, because heart is where all the volume is coming. So atria, once they feel, okay, a lot of fluid is coming, we have to get rid of it. There's a specific system there, which is the atrial natriuretic peptide, which then goes on and does two major things. One is it will cause loss of sodium directly. And secondly, it will inhibit aldosterone. So any condition where the volume increases, ANP will be more. Now, what role does ANP have? Do you know of any condition which is causing hyponatremia where ANP is causing a problem? Vibha. So any condition with high volume, let's put it this way, you have cardiac failure, you have liver disease, you have renal failure, you have got SIADH. SIADH is actually a hypervolemic state. As soon as the volume goes up, ANP goes up. So ANP is the second perpetuating mechanism which is going to cause your loss of sodium. So now let's go this way. We said that you have too much free water or you have loss of sodium. That is why your sodium becomes less in that perspective. If you have got too much volume, ANP comes into the picture, that will cause more loss of sodium in that perspective. The other thing would be that if you have got less volume, then which thing will come into picture? RAS axis and AVP will come in. If you have less volume, AVP will come in, and AVP will also cause more free water. So in a way, there are two mechanisms which increase this vicious cycle of hyponatremia. One is that if you have too much volume like SIADH, your atrial natriuretic peptide will come into the picture. It will cause sodium loss. While if your volume is less and you are severely hypovolemic, I'm not talking about 2%, 5%, I'm talking about 10 to 20% dehydration, then atrial, then AVP, the vasopressin will come up, and that is going to cause you further hyponatremia. Now, the main problem with high ANP in SIADH is that if you give them sodium, what is going to happen? You say, okay, they are hyponatremic, I'll give them normal saline. What will happen then?
You can give normal saline because of the ANP action, sodium loss will be there.
So body is ready to lose sodium. So as soon as you give sodium chloride, it will lose all the sodium. It will, because the ANP is high and aldosterone is low. So that's a tricky situation. So if you understand this slide, you will basically understand the entire pathophysiology from that perspective, and that becomes important from that regards. Now, if we know now this much, we'll now move forward to the what could be the causes of hyponatremia. So as I said, hyponatremia is largely a free water issue. So most cases of hyponatremia are because of having too much of free water. Like hypernatremia is because of too little free water. It's just the opposite thing. So you may have more free water because of a cardiac failure, nephrotic syndrome, chronic liver disease. Those situations you will have more volume. Now here you have effective hypovolemia. There is a third space collection. Because of effective hypovolemia, your RAS axis will go up. So your potassium, you will have hypokalemia, alkalosis may happen. Your AVP will also go up. And that's why also you will have further worsening of hyponatremia, which will happen. Then, of course, if you have any reason for body to produce AVP, which is inappropriate, that is SIADH, and there are so many causes. What are the major causes of SIADH in children?
SIADH will be secondary to the infective cause.
Like?
Or pulmonary infection or
largely in the setting of bronchiolitis, pneumonia, meningitis, tubercular meningitis, these will be the features. But don't forget about drugs. A number of chemotherapeutic agents, vincristine, vinblastine, cyclophosphamide, ifosfamide, they will also cause a similar picture. A lot of SSRIs and substance of abuse, ecstasy, these all drugs will also cause. So these drugs, infections, these are the largely two things. And I said porphyria also as one of the causes, and mechanical ventilation, Guillain-Barré syndrome. There's so many causes, but you have to consider SIADH importantly. Very important to remember that if you have a deficiency of thyroid or cortisol, you will also have increased volume and causing hyponatremia. Now, my question to you, Vibha, is that if you have somebody who has got an isolated cortisol deficiency, what will happen to potassium? So the message is that if you have hyponatremia, even if the potassium is normal, it does not mean that you have ruled out cortisol deficiency. When there is a combined adrenocortical deficiency, both cortisol and aldosterone defect, you will have hyperkalemia, which will happen in that setting. While here your potassium levels may actually be normal or low. So look at sodium, don't just look at potassium in that perspective. The other big message is from the first case, as I said, that if you have got anybody with your diagnosing SIADH, always exclude thyroid and cortisol deficiency, because that's very, very important from that regards. Now, sodium loss can also happen, but this alone is not good enough. You will need to sustain it either via excess AVP, and that is going to cause it more worsening. This sodium loss could be a RAS defect or tubulopathy. What would be the difference in potassium levels in RAS defect versus tubulopathy?
potassium level in RAS defect will be high. It is hyperkalemia. In tubulopathy, sodium and potassium both will be low.
Okay, so very good thing to know is that if you just know potassium, you can classify that. So now how will you distinguish? Now, if you build up approach here only, it becomes very easy. If your volume is more, you are dealing, or your volume is more, you're dealing with these conditions. If your volume is normal, you're dealing with SIADH or hypothyroidism cortisol deficiency. If volume is less, you're dealing with either RAS defect or tubulopathy. There you do potassium. So all you need to know is the volume status, potassium. Maybe if you are in doubt about the volume status, look at hematocrit and uric acid and urinary sodium. These 4 or 5 tests will really tell you which is the diagnosis, how you should go ahead in terms of treatment from that regards. And of course, diuretics, cerebral salt wasting, these all factors are there, which you will know that there is a CNS insult and there is a salt wasting which is there. So hyponatremia can be because of excess free water, which is basically associated with U, or hypervolemic with a low uric acid because you have got more volume. The cause here, or sodium loss, in which you will have a hypovolemia with high uric acid in that perspective. Excess free water can be cardiac, liver, or renal in that perspective. And in this setting, your urinary sodium will be low. Why is the urinary sodium low in this setting?
Sir, again, volume deficiency.
So there is a intracellular. So it's the third space loss is there, but actual you have effective hypovolemia. So body is conserving. So you will have a urinary sodium which is low in that setting. While reduced loss is largely SIADH or cortisol deficiency, the urinary sodium here will be more than 25 in that perspective. Now, sodium loss can be extrarenal like diarrhea and cystic fibrosis, where body will then like to conserve the urinary sodium. It will be less than 25. And finally, renal loss, which can be either tubular or adrenal, where the urinary sodium will be more than 25. So if you look at 2 levels, I talked about volume, U versus hyper, and urinary sodium, you know which way you're going. If you want to distinguish tubular from RAS, look at potassium. So if you just remember this algorithm and look at volume, potassium, and urine sodium, your diagnosis is done. It's not very difficult to do in terms of hyponatremia evaluation. Now, one question which is easy to say but difficult to do in practice is it free water excess versus sodium loss? Because that's the fundamental thing. So of course, you want to look at volume. But often in small children, volume may not be very easy to say whether it is euvolemic or not. So fluid status will be one, of course. But as I said, you can use other surrogate parameters. If your uric acid is low, if hematocrit is also low, it means there is a hemodilution which is happening. While if you have got high uric acid and a high hematocrit, it goes more in favor of a concentration. So again, renal versus adrenal. This is the question which often happens. Your answer would be hematocrit. So if you have somebody who comes to you at 4 weeks of life with hyponatremia, hyperkalemia, and has a hematocrit of 68, it is unlikely to be adrenal because creatinine may be high even if it is a pre-renal failure. So that may cause a confusion. So there is hemoconcentration. It means there is a problem in the adrenals, not in the kidneys. In that reading. So main test to look at are potassium, uric acid, urinary sodium, and these ones will give you the diagnosis. So let's go one by one. Uric acid will be low if your fluid is more. So I find it very, very helpful in differentiating between SIADH and cerebral salt wasting. Now, this is a typical setting. Somebody is in the neurosurgical ICU, is developing hyponatremia. The question is it CSW versus SIADH? Now, to distinguish between the two, you can say, okay, look at the volume status. There is hypovolemia or not. You look at the level of urine output. It may be of help in that perspective or not. And the other situation would, of course, be to look at uric acid. So uric acid will be less than 4 in that setting. And I often find it less than 2, which becomes very, very easy to distinguish between these two conditions. Urinary sodium, I said, if the urinary sodium is high, it means you're losing through the urine. That is the basic cause. Potassium, if the potassium is hyponatremia with hyperkalemia, renal versus adrenal. Hyponatremia with hypokalemia, tubulopathy or GI loss. And normal may be all these SIADH, fluid overload, these conditions will give you a picture. And hemoglobin is again a marker of concentration. So hematocrit will be a good picture. So not many tests are required. Basic tests will give you the diagnosis. So look at fluid status. Of course, you have to exclude a possibility of hyperglycemia, which may cause pseudohyponatremia, but you will know that this patient has decay. There's no confusion. Ion selective electrodes that we are using now will not be affected by increased amount of lipid or protein. So that's not a big problem now. If fluid status is hypervolemic, you know these three conditions, cardiac, renal, and these patients you will know that there is a liver disease, and then they will have hyponatremia. They will not come the other way around. If they're euvolemic, do a thyroid and cortisol. If it's normal, it is SIADH. If it is low, it is MPHD. Work up accordingly. The issue is here, if you have hypovolemia, then urinary sodium, if it is low, it is extrarenal. If it is more, look at potassium. If there is hyponatremia with hypokalemia, think of tubulopathy and diuretic use. If there is hyponatremia and hyperkalemia, think of a RAS defect and evaluate accordingly from that perspective, which is there in that regard. So we'll take a couple of cases and then we'll move forward to our grand round cases. A 3-week-old child with failure to thrive with hyponatremia is not gaining weight, dehydrated, and PCV is 62. Now, if you look now, fluid status is hypovolemic. So renal causes are anyway out. What we are seeing here is that urinary sodium is high, potassium is 8, diagnosis, RAS defect. And when you see the child, clearly has a atypical genitalia with non-palpable gonad. I think the most common cause of RAS defect in this setting is a 21-hydroxylase deficiency, very simple to identify. So hyponatremia, hyperkalemia, high urinary sodium, atypical genitalia, early onset dehydration, classically suggestive of CAH in that perspective. Second child, 1-week-old boy with hyponatremia and hypokalemia. So RAS defect is off. It can't be a RAS defect. Renal failure, off. So we have to think of other causes. No dehydration, so euvolemic again, and there is hypoglycemia. Now this is a big thing. Two things going down, sodium and glucose, which is ketotic. I think we are heading towards the endocrine cause, which makes it much more likely. There is micropenis, so again, you will get a diagnosis that this is a multiple pituitary hormone deficiency. Remember that people may say this cortisol is not low, but for the level of sodium, for the level of glucose, it should be more than 550. So this is a relatively low level of cortisol, which we are seeing, and that will be a problem in that perspective. So this becomes important and assessment becomes important from that perspective. So before we start off with the discussions, there are a couple of questions which we'll take, and then we'll start the cases right away from there. How do we treat chemotherapeutic reagents in SIADH, whether we need to hydrate the child well, as would be there. So we'll talk about these issues a bit later about how to manage SIADH. That's an important issue. Now, this is a big question, SIADH and salt wasting. Of course, if you are able to document polyuria, it goes more in favor of a cerebral salt wasting. If a patient is dehydrated, it is more in favor of a salt wasting. If your urinary sodium is very, very high, it goes more in favor of a cerebral salt wasting. But the most important thing is that if the uric acid is high, it goes in favor of CSW. So I will say urine output, hydration status, uric acid, these will be important. Plasma osmolality, not important, because if your sodium is low, your plasma osmolality will be low. So both of them will have a dilute blood. Now with the dilute blood, how much is your concentration in terms of urine may give you a picture, but more important will be whether you have dehydration, and that will become important from that regards. So what we'll do now is that we will carry forward with our discussion and we'll take our first case. I'll invite Dr. Manoj, who will start off with the first case of today. So Dr. Manoj.
Thank you, sir. So we have case of 10-year
1-year-old girl born of non-consanguineous marriage who was brought to our OPD with the chief complaints of recurrent episodes of cough, cold, and difficulty in breathing since 6 months of age. Now coming to the past history, because there are many significant events in the past. She was born full term with a birth weight of 2.7 kg and there was no history of any NICU stay. The mother told us that at 3 months of age, She was admitted to hospital with multiple episodes of loose motions, vomiting, and refusal to feed, and decreased output. She was managed, and some investigations were there done at that time in the hospital, and she was discharged. But after that, she had frequent episodes of cough, cold, and difficulty in breathing. Those cough and cold were not associated with any seasonal variations. She also has a history of not gaining weight. With these complaints of respiratory infections, loose motions, vomiting, she has been admitted to the hospitals for a number of times, and where she has been managed symptomatically, and a number of investigations were done.
So roughly what we are talking about is a child who has failure to thrive with recurrent respiratory situation. What are the possibilities you will think of?
So, first, the most common conditions is the malabsorptions, which is the most common in our country, like frequent respiratory infections, and second could be like cystic fibrosis, where there is a recurrent history of recurrent infections, and there is failure to thrive.
Cardiac cause?
Yes, sir. This
so you have to consider because we know the diagnosis become more common. But otherwise, if you have recurrent respiratory difficulties, failure to thrive, cardiac problem,
cardiac infections, yes, sir. And sir, GERD also, because the patient is vomits after feed, and there's not able to gain weight, and there is a frequent respiratory infections that could be the cause. And there is a history of 1-2 episodes of rashes over tongue which were associated with itching. There is no history of similar complaint in the family, and there is no history of any asthma, allergy in the family. No history of any sibling death, no history of any greasy stools, and no history of any hyperpigmentation in the body of the child. There's no history of any regurgitation of feeds, excessive cry after meals. Child developed normally well. She achieved milestones as per her age. On the examination, when she came to us, and she was having cough and cold, and there was temperature of 101. She was tachypneic. Mild nasal flaring was there. Mild subcostal retractions and bilateral wheezing was there. Genitalia was absolutely normal. There was no clitoromegaly and no hyperpigmentation. Anthropometry, the length was weight 9.4 kg, SDS minus 0.17, length 74.5 centimeter, SDS minus 1.10. Now coming to the investigations, they brought so many investigations with them, which shows that on seeing the investigations, they show a trend of hyponatremia on a number of events, like they have a.
Now, if you look at these figures, you are seeing there is hyponatremia and hyperkalemia.
Yes, sir.
But if you compare the last case which was presented, the sodium was 116 and potassium was around 6.5, 6.1. But here what we are seeing is a bit different.
Yeah, the hyponatremia is mild. It's not severe as compared to the previous case, and potassium, this hyperkalemia is severe.
So while I've been saying that if you have hyponatremia with hyperkalemia, think of a renal or a adrenal cause.
Yes, sir.
Renal cause, of course, creatinine would have been done because normal.
Normal, yes, sir.
Potassium and sodium relative levels also give you a picture.
Yes, sir.
If you have very severe hyponatremia with hyperkalemia, it means it has to be a
combined effect. Yes, sir.
If there is a mildish hyponatremia and there is hyperkalemia, which is much more, it means
it is related to the aldosterone defect.
Why do you have milder hyponatremia and aldosterone defect than in cortisol combined with it?
So because
aldosterone is a major regulator of sodium potassium in it. We said that you have sodium, 97% of it is resolved in the proximal tubule, 2% is resolved at the collecting duct, 1% goes out, and that 2% absorption is largely regulated by the aldosterone and the mineralocorticoid receptor.
Yes, sir.
So if your aldosterone is defective, why is your sodium not that low? Here. But if you also have cortisol deficiency, your sodium is worse.
So because sodium, when cortisol is working, this ABP also causes water retention. This cause
So the second
sodium
important point
deficiency.
that I said immediately was that anybody to have a long-standing hyponatremia, you would need an ABP axis.
Yes, sir.
Now, cortisol inhibits ABP. Cortisol is also involved in free water excretion. So, if your cortisol level is also low, your ABP will go up and your free water excretion will go down. You will have severe hyponatremia.
Yes, sir.
This is a living example of that thing. That unless you have ABP excess, your sodium will not be very low.
Yes.
You will have marginally low sodium. Potassium will be the major problem. So if you have this is a classical presentation of pseudohypoaldosteronism. If you have a child who is failing to thrive, not looking very well, but not very sick also, and no pigmentation, there is hyperkalemia, and the sodium is slightly low, this is classically of a RAS defect, mainly at the level of aldosterone production or action. Now, you are seeing that there is acidosis also.
Yes, sir.
Why is there acidosis?
So because this potassium is not being absorbed, because the potassium here is a defect, as you said, there is a defect at the aldosterone this receptor. The potassium is not being absorbed. This is not secreted. So this this proton is also not being secreted in the humans. So there is,
potassium wants to go out of the body. It will stop proton from going on because they are competing with each other. So hyperkalemia will inhibit ammonia production, and that is going to cause your major loss of protons will be less. And that's why whenever you have hyperkalemia, you will have acidosis. This is what is type 4 acidosis. So this is a classical picture of a RAS defect. Just by looking at a single listing, you can make a diagnosis. Carry forward.
The urine routine was normal. There was no pus cells, and USG KUB showed this. There was no urinary tract obstruction, and the adrenal size were normal. 17 OHP levels was normal, and there was normal cortisol level.
So why did you do the urine RM in ultrasound?
So because the this urinary obstruction of the UTI can cause transient aldosterone resistance, that's why they were done.
Okay.
And as we can say, the plasma renin activity was, the level was high. This is 20 nanogram per ml per hour, and normal is 7.7 to 11.2, and aldosterone is also high, that is 130 nanograms. So we can see.
So this is a classical case of hyponatremia, hyperkalemia, and you show that cortisol levels are completely normal. And there is high renin, high aldosterone. So this is clearly a case of pseudohypoaldosteronism. Now, which form are you talking about?
So we can say there is two forms like renal and systemic. As a child is having recurrent this respiratory infections, so this disease is not limited to the renal only. It's also the involving the systemic like lungs and other things. So this is the systemic generalized PHA1.
So this is the severe form.
Severe form.
Sodium chloride channel defect, the PHA1 classically. And that is what is the most relevant part coming out of your case, is that this may actually present to you just with recurrent respiratory symptoms rather than a salt wasting crisis. Crisis happens when you have cortisol deficiency. Let's put it this way. If this was CAH, this patient would not have survived till now. They would have presented with crisis much earlier. Here, crisis will not happen, but potassium hyperkalemia may be dangerous, and they are also accustomed to hyperkalemia. I have never seen patients who have got patients potassium of 10, 11, CAH, you won't see that at all. Here you can see very high potassium, because maybe the body is adapted to the cardiac adaptation that happens.
So we have a 1-year-old girl with the normal genitalia with recurrent respiratory infections and salt wasting syndrome like vomiting, failure to thrive, and dehydrations. If we see only the respiratory tract infections, we can think of like Walry, cystic fibrosis, GRD, and allergic asthma, but the symptoms are also combined with the vomiting, failure to thrive, and dehydration. So it could not be Walry or just cystic fibrosis or GRD. It has to be something else. And if we see only the salt wasting like 21 OHT or AHC steroid defect,
so basically now if you combine that and when you look at this picture, there is not much confusion. There is hyponatremia with hyperkalemia with a volume which is low, which means renal is out. In that setting, you don't have any pigmentation.
And normal genital is aldosterone.
The diagnosis is very clear.
And when the genetic study was done, we see the mutation in the SCNN1B gene, which encodes the beta subunit of the ENC channel.
So epithelial sodium chloride channel is the channel which takes your salt out of the kidneys, and in exchange of that salt, you are losing potassium and proton. So if this channel is defective, you will lose sodium. That's why you have hyponatremia. You will lose chloride. There will be hypochloremia. You will be gaining potassium, causing hyperkalemia, gaining proton, causing acidosis. So this is a classical picture of type 4 RT.
The treatment given to the patient is this fludrocort, the 0.6 milligram per day. The highest dose we can go to is 1 to 2 gram per day.
Normally, if you talk about your patient, you are giving 1 tablet, which is 0.1. Here we are giving 6 tablets, which is a huge dose. So what we're trying to do is to actually give so much fludrocort that it overcomes the resistance. So that is what is being tried in that situation.
Soda bicarb for the acidosis part, and this 3% NaCl for
what you're doing.
salt supplementation.
You're losing salt, it is not being absorbed. You're giving more salt and you're giving aldosterone with an aim to reduce it from that perspective. This child is younger, has no pigmentation, has got major hyperkalemia with lesser hyponatremia. So I think this all means an isolated aldosterone defect. An isolated aldosterone defect at this age, PHA will be most likely. Because there is recurrent respiratory symptoms, it becomes more like a PHA1. There is no UTI, there is no obstruction. Of course, it can't go on for a year. So this, of course, is a more of a genetic cause rather than a local cause in that perspective and regards. So very important to remember is that salt wasting crisis is a major presentation, which usually presents in the newborn period or sometimes with adolescence, which is missed, with dehydration, shock, hyponatremia, hyperkalemia, acidosis, and hypochloremia. Now, this child had hyponatremia, mildish, hyperkalemia, acidosis, but did not go into crisis because the cortisol was there. Without cortisol, the first child would have gone into that crisis very quickly in that perspective. The differential, of course, is renal versus adrenal. And as I said, dehydration will give you a picture immediately in that perspective. And again, if you have hypervolemia, low hemoglobin, uric acid is normal and urine output is low, this is renal, while adrenal will be dehydrated, hemoconcentrated, high uric acid. So again, hydration status becomes a very, very important thing to look at from that regards. Now, one important confusion which often happens in most cases of salt wasting present in the neonatal period. So you need to understand about how do you distinguish between neonates with salt wasting. So if you have 21 hydroxylase deficiency, this will basically present as either a XX-DSD or a normal appearing male. That will be the situation. Adrenal will be enlarged and aldosterone will be low. If you look at 3-beta-HSD and POR, they will cause DSD in both. So atypical genitalia, both of them will be there. Again, enlarged adrenal with low aldosterone. Star will cause DSD in boys, while will have a normal female genital appearance. Large adrenals will also be there and aldosterone will be low. While if you have adenohypoplasia congenita, this is an important differential in with gender, because it's an X-linked disorder. You will have normal genitalia with small adrenal. So adrenal will give you a picture here. And of course, you have pseudohypoaldosteronism where the genitalia will be normal, the adrenal size will be normal, and aldosterone will be high. And I will add to that, if you have predominantly hyponatremia with high potassium, it is combined. If you have predominantly hyperkalemia with slightly low sodium, it is more like a PHA or pseudohypoaldosteronism as we saw in this case. So how do you approach a newborn who presents to you or an infant who presents to you with salt wasting? First and foremost, if you have hyponatremia, hyperkalemia, rule out renal cause. Then you do infection and obstruction. This has to be ruled out. Then what we've developed an algorithm is that if you look at the genitalia and the genitalia are atypical, the next question is it XX DST or XY DST? Look at palpable gonads. If the palpable gonads are not there, the most likely diagnosis is 21 hydroxylase deficiency. Look at 17-OHP. 17-OHP is high, very high, 21 hydroxylase. If it's borderline, think of 3-beta-11. These sort of situations can happen in that regard. However, if you have a salt wasting infant who has got an atypical genitalia with a gonad, now 21 hydroxylase deficiency is out, then you start looking at other things. DHEAS level, if DHEAS is low, this is a star, Steichen-Cheeves defect. If it's high, it could be 3-beta-HSD. If your genitalia is normal, now normal genitalia with salt wasting, most of these cases will be boys. So if you have a male, look at 17-OHP, very high, this is CH. If the 17-OHP is not high, look at adrenal imaging. If the adrenals are small, that's adrenal hypoplasia congenita. Now, if you are female with normal genitalia and who have salt wasting, the next thing is to look at 17-OHP. If it's very low, it is star. This is going to be very, very rare in that perspective. If the 17-OHP is normal, or here the imaging is normal, you look at aldosterone to classify into hypoaldosteronism versus pseudohypoaldosteronism. So three things to look at in somebody who comes to you with salt wasting. First, what is the genitalia? Gonads there or not? And 17-OHP. Here again, look at 17-OHP and imaging. Not too much workup and you will get the diagnosis right away. If you go at this child, normal female genitalia, you would do 17-OHP normal, you do aldosterone. So directly we are going into that direction in that perspective that we are looking at in that regards. Now, pseudohypoaldosteronism is basically a problem at multiple levels. You can have a problem in the mineralocorticoid receptor, which is a reversible form. You can have a problem in the epithelial sodium chloride channel, which this child had, the more severe form, the systemic form, and this is there. And then you can have a transient problem because of obstruction or UTI, which improves. So always do a urine routine microscopy, always look at ultrasound, give a course of antibiotics, and they may improve in that perspective. They will have hyperkalemia, high aldosteronism, mildish hyponatremia will be there. Now, how do you treat? As we discussed, you give too much salt. The only role of epithelial sodium chloride channel is to increase the amount of salt that you are getting absorbed. So if you're taking 2 grams, you are absorbing 0.2. If you take 10 grams, you will absorb 1. So the concept is give a huge amount of salt. You may overcome this problem. The second way is that you give more, and if you give too much sodium, potassium will also be lost. The second is aldosterone, give at a high dose. Aldosterone is the one which pushes this epithelial sodium chloride channel to the membrane. So if you give it 10 times, 20 times, you may be able to circumvent. So it's more like a not a absolutely physiological way, but what you're trying to do is that you want to overwhelm the kidneys. Give too much sodium, too much fluid record, thinking that body will take it over in that regard. So if nothing happens, give IV infusions. I have seen patients who required multiple IV infusions, maybe daily. Once they grow up, it becomes easier, but this could be a challenging situation. Now, other, of course, option is to produce a apparent 11-beta-HSD deficiency. And drugs like carboxynoxolone may actually inhibit it. And what will happen there is that your cortisol will now start acting on the mineralocorticoid receptor. And you've got a huge amount of cortisol, so their effect will be much more. So mainstay of treatment of pseudohypoaldosteronism is to give too much salt. If required, soda bicarb, as in this case, there the acidosis was much more, but usually acidosis will improve once you give enough sodium, and a high supraphysiological dose of aldosterone is what you can give. The treatment depends upon how much is the duration and how much are the symptoms. So duration we talk about, More than 48 hours is chronic, less than 48 hours is acute. So the duration is less than 48 hours and you have got severe symptoms like seizures or impending respiratory failure, sodium other than 120, you have to immediately give a 3 to 5 ml per kg of 3% saline. You can rise the sodium by 9 to 12. If there are mild to moderate symptoms like only headache and confusion, like maybe in this case you can say, you will have 120 to 130, you will give slow dose of 3% saline and build up by 8 to 9. Now remember, if you give somebody with cortisol, especially in somebody who has adrenocortical insufficiency, the sodium levels may rise rapidly. So you have to be very cautious that the sodium levels do not rise very rapidly more than that, because that can cause a problem. If they are rising a lot, you have to either do a relowering using a AVP, and that becomes important from that perspective. If the duration is about 48 hours or you don't know, often you don't know how long is the symptom, then you assume it is chronic. Then depending upon symptoms, if they are severe, you still may have to give 3%, but the dose is there, the same dose, but then correction is slower. After that, your aim is to correct seizures and then hold. Don't build up very rapidly. And if it's mild to moderate with nausea only, no need of 3% saline, you give restriction, treat the cause, and you will go. So symptoms and duration will decide what treatment to do and how do we go forward from that perspective. That becomes relevant from that regards. So I think that was a very, very interesting aspect which we discussed today. You can explore our books, courses, and applications. Fludrocortisone, a good drug for cerebral salt wasting? Yes. So main treatment now, this is a very debatable issue whether the cerebral salt wasting is actually a condition or not. A lot of people debate that, but main treatment is a lot of sodium chloride, and fludrocort will help in that regards. What are the reason for cortisol deficiency in this case? The MRI, I think, is normal on that. We are looking at some genetic causes as a possibility to work it up on that. We are waiting on that in that situation. There are other questions. Cutoff for mild, moderate, and severe. There is no sodium cutoff. Now, this is important to remember, Dr. Amit, that we depend upon the symptoms. We don't go by the levels, because the symptoms and the presentation depends upon the rapidity of fall. So if somebody is at 120 who is having seizures, who is coning, that is severe to me. But if somebody is 115 and doesn't have that symptoms, chronic liver disease, it's not severe. So it's a combination. So if you remember that algorithm, duration and symptoms, they will give you the diagnosis and how to go forward on that. For sodium correction in hyperglycemia, 1.8 is what we usually recommend, and some 2 is also okay, but 1.8 seems more reasonable, Dr. Munir, in that.